Dr. Ajay Aurora will speak on Micropulse laser principles and his experience in managing chronic CSR, venous occlusion and DME.
Thank you, sir. And I thank the organizers for the opportunity. I'm talking about subthreshold micropulse laser principles and my experience in managing chronic CSR, venous occlusions, and DME. So what I'll be talking is a basis of micropulse laser and my experience in these conditions. There are other conditions in which we have used subthreshold micropulse laser is ERM with macular edema, post-radiation macular edema. So basically, you must understand what micropulse laser is all about. It is not a continuous wave laser. It's a laser which has been split up electronically into small components. So there is an on time and an off time, and it is the off time that matters most. So that is why we can have 5% duty cycle or a 10% duty cycle or a 15% duty cycle. So a sub-threshold continuous wave scanning laser is not equivalent to micropulse laser. In a micropulse laser, there is 100% tissue sparing, while a sub-threshold laser, there could be an obvious damage of the OCT, which can be detected once we on the OCT as such, but in a micropulse laser, even the OCT damage does not occur. The wavelength to choose is 577 microns. And this shows you the mechanism by which a micropulse laser works. It is actually releasing the heat shock proteins, and these have an anti-angiogenic and tissue restorative factor. The modality of using a micropulse laser has been now shown as a low intensity, high density application, which means when you give the pulses, there is no interpulse or an interspot distance. So they do not overlap, but there is no distance between the two. So this is a low intensity, high density distribution. These are the basic facts about CSR, but because of positive time, just to say that we do not treat acute CSR, you must take care of all the factors like stress, smoking, and antioxidants. So I'll be talking on, and I have actually almost stopped giving apnea to my patients. There are various other agents indicated, but I would continue on antioxidants and treat them with micropulse laser. We now have about 34 patients with a follow-up of 18 months to 7 years in these patients with a mean age of 39 years. We are coming out with a major publication on this, with a pre-MPLT visual acuity of 0.5, post-MPLT visual acuity of 0.72, and a mean NSD of 230 microns with a reduction of 72.3 microns. So I'll show you these cases. So this was a patient who was a laparoscopic surgeon, a 47 years old male, who was diagnosed CSCR in 2015. He has been treated with all modalities of treatment, including a thermal laser. You can see the spot of a thermal laser here. And he came to me and I suggested that we do micropulse laser. After treatment, he asked me, why was I not told about my subthreshold micropulse laser earlier? So this is his picture. I followed him up now for 4 years. There have been 3 episodes of micropulse laser treatment in this patient. So this is pre-micropulse and this is post-micropulse, and he did well. This is an ophthal resident. He has now finished his post-graduation. And he used to drive down and come to me with his the CSCR. We treated him, managed him well. He was under tremendous amount of stress. So this is the first treatment he received in November 2018, which was followed up with, there was a reduction of neurosensory detachment, as you can see here. He received a second treatment here and then was followed up in February 2019. The fovea was absolutely flat with disappearance of a neurosensory detachment, and he did well. This is a dentist who has been under various forms of treatment with apnea, transpupillary thermotherapy. He was a smoker. We did his angiography, and in Octa, we found that his right eye had a pachyneovasculopathy with a neurosensory detachment, which was treated with ILIA. This was then followed up by treatment with micropulse laser in both eyes. So he received micropulse laser, and we called him, and he came back after about 3 weeks. So just to point out, in all the patients whom we have followed, we find that neurosensory detachment can actually increase after micropulse treatment in first 26 days. So they have been varying periods in these cases, but eventually in about 6 to 8 weeks, this flattens off. So we do not repeat treatment for about 2 to 3 months, and the patients did well. So the take-home message from these cases, I have now a large series of patients that SMP works in cases of chronic CSR. We've had a success rate of almost about 96%. It is not a one-time treatment. It may need to be repeated. For the initial effect to come, it may take 2 to 3 months. The NSD may increase immediately after laser, but gradually it settles down. Please rule out a secondary coronary neovascular membrane before treating micropulse laser. So this was an army general who had come to me with non-ischemic CRVO. He knew everything about anti-VEGFs, and he said, I do not want any anti-VEGF injected in me, and I have now followed him up for many years. And we gave him a subthreshold micropulse laser, and this is his sequential pictures over a period of time, and he responded well. We have been managing him since 2015. This was a 23 years old female, non-diabetic, non-hypertensive, possibly an inflammatory branch lateral venous occlusion with a homocysteine of 7.1, and she received 2 Avastin injections for her macular edema with branch vein occlusions. This is the second injection which she received, and then for some reason she said, I am not willing for repeat injection of Avastin. And you can see here a large area of capillary non-perfusion, which we treated with a sectorial micropulse laser of 10% duty cycle. This is a sequential angiograms of this patient. You can see the neovascularization of the disc having become more fibrous with reduced leakage, and this is serial OCT of the same patient. I followed this patient now for almost 9 years. And she has now moved out of India. She's in Ireland now. And she comes for the annual checkup, and she is doing pretty well, maintaining a visual acuity of 6x6 parts. This is a Whitefield Octa, and she's done well. This is another patient of BRVO who came to us during COVID times, was not vaccinated, developed a branch lateral venous occlusion, received injection eccentrics, and subsequently we decided to do micropulse laser. For the macula, we did 5% duty cycle. For extra macular area, we did 10% duty cycle. And now I have followed this patient again with OCT and an unfast imaging. And this is his picture. He did receive a small focal laser for the small NB he is developing, but for this large area of capillary non-perfusion, he has been treated with micropulse laser and is doing well. It's been shown by various authors that micropulse laser is as good as modified ETDRS protocol of focal laser being used. So we have treated a few patients with micropulse laser. Obviously, metabolic control is extremely important. And we have done a micropulse laser pan-retinal photocoagulation after taking a due consent that this is not a prescribed treatment for cases of PDR, but these patients have stabilized, and we have followed up sequentially with field charting and shown that the fields do not deteriorate, which would have otherwise happened if we had done a normal PRP. So the question and a take-home message to all of you is, if you do not have the ability to do a micropulse laser, at least refer the patient, especially of chronic CSR, where this ability is available, so that the patient does not ask the question, why I was not told about subthreshold micropulse laser. Thank you very much.
Thank you, Dr. Ajay.